Hi, everyone. We're going to go ahead and start. We'll just go ahead and accept people as they continue to trickle in. I just want to start off by saying hello and welcome to week 2 of the virtual Winter Health Education Series presented by the Healthy Southwest. Today's session is about senior care for seniors and senior care providers. My name is Isaac Marufo, project coordinator for CDPH. I work closely with SWAP in the Healthy Chicago Equity Zones. If you have any questions that come up during the presentation, please use the Q&A function where our presenter, Dr. Luna, will have roughly 10 to 15 minutes to answer questions at the end of the session. Note that questions will be anonymous. I would also like to remind everyone that the recordings for both English and Spanish sessions today will be available on the Southwest Organizing Project's YouTube channel. So a little bit about CDPH. I'd like to start off with our mission. CDPH works with communities and partners to create an equitable, safe, and resilient and healthy Chicago. Just to talk a little bit about what we do, at the Chicago Department of Public Health, we fight to eliminate health inequities, work to improve systems, and leverage our diverse staff, community, and partners to remove barriers of health. We also support the broader public health system through data analysis and dissemination, policy change, and citywide planning activities to promote equity. We work in programs including health protection, maternal, infant, child, and adolescent health, community health, behavioral health, syndemic infection diseases, and public health emergency preparedness. A little bit to talk about our health equity. Is CDPH is committed to reducing the Black-white life expectancy and creating a healthier future for everyone in Chicago. So CDPH's Healthy Chicago 2025 plan is a call to action across sectors to promote health equity with the understanding that health inequities are rooted in racism and cause harm to individuals and communities. So with that being said, please make sure to follow us on our social media networks at Shy Public Health. And for any more information that you may be interested in looking into, please visit our website at chicago.gov/CDPH. And with that, I would really like to introduce our presenter for today. Dr. Luna is a medical director at the Chicago Department of Public Health, at the COVID-19 Response Bureau, and executive board director at the Medical Organization for Latino Advancement. She has been involved in healthcare for more than 13 years, focusing on geriatric and internal medicine. Dr. Luna is a graduate of the University of Illinois at Chicago in internal medicine and geriatrics subspecialty and master's in public health. Additionally, she has completed an executive master's in business administration at Northwestern University, Kellogg School of Management. So definitely a great honor to have you here, Dr. Luna.
Thank you. It was muted. Thank you. Thank you for having me, everyone. It's a real pleasure and an honor. Always community engagement and having these conversations, which are so important. When we're managing decisions, right, and the information to make those informed decisions. So, if I can share the screen, I would love to do that, Priyanka. Today, after conversations with the team, we understand that there's a lot of topics that the public needs information about, especially our geriatric population, which we know that in this pandemic and all respiratory conditions and anything that has to do with challenging the immune system have suffered the most, especially now that we're in winter with all these surges that we're seeing in influenza and also we're seeing in COVID-19, which is nowhere to leave us anytime soon. So when we're talking about other conditions, and these are chronic conditions that equally affect our life and can make us disabled after a certain age, we're talking about osteoporosis. And just to give you a little bit of understanding what osteoporosis mean, osteoporosis is a bone disease. And this disease develops when bone mineral density and mass decreases. And this happens throughout age. However, not every elder individual suffers from osteoporosis. So there is a couple of elements, environmental, and there is also intrinsic elements that we will touch very quickly here. Remember, this is a such a vast topic, so we want to simplify it for you to make decisions and understand if you might be suffering from osteoporosis and the early intervention because is reversible. So what we want to know is, and we want to discuss with you is that the bone density is so important to keep the strength of the bones and increasing. And if you don't have that bone density that you need, there's increase in fractures, increase in hip fractures, disability that comes afterwards. And the important thing about osteoporosis is it's a silent disease. People are not normally diagnosed with osteoporosis unless there is a bone fracture. And then when they start discovering and looking a little bit further, because it's not really private preventive. There's no imagings that you do aside from the ones at 65 years old, looking at bone density, which has become part of preventative measures for elderly. But before that, there is that window that individuals might be developing osteoporosis or fully blown have osteoporosis. So this is an important thing because it also affects women most likely, but it also affects men. And woman postmenopausal, it's a state that might predispose you to suffering from osteoporosis. And the first fractures that we always see is hip, vertebral or vertebral in the spine, and wrist. So, what is a normal classification? And we do this a bone density study. And a lot of people are like, Dr. Luna, I really don't know what we're talking about here. When you go to your office and your doctor starts examining, either you're instituting primary prevention, instituting primary care with a doctor, or they already know you, but that you're already at that age that we need to sit down and have those discussions. There's a couple of things that we do. One is this 65-year-old bone scan that we order as part of preventative care. And there's also the FRAX, which I'm going to tell you a little bit about it, is a tool that just by taking the information is very good at predicting. And now it's widely used in the United States as an early sign or warning sign that this individual or the patient itself might be at risk of developing osteoporosis. So normal is anything when we do a bone scan, which is within the normal reading, and the T score is somewhere around less than one, a little bit more, I'm sorry, than one. And when we're talking about osteopenia, is the first signs of loss of the bone, and we're talking about two standard deviations already that we see. One standard deviation of 2.5 from the normal, or when our T score, which is also information that we get with these imagings, is about one and in negative point 2, 2.5. Osteoporosis itself is when we fall below negative 2.5. And then when we're talking about severe osteoporosis, is any of those readings falling way below that negative 2.5? And then we know we need to institute, like, give, for example, pharmaceutical or medications to try to reverse this state for the patient. And then it's high prevalence, believe it or not, more than 2 million osteoporotic fractures are reported annually in the United States. And one of two postmenopausal women and one in five men over the age of 50 are at risk, or at least reporting one of those fractures happening in their lifetime. There are serious consequences that can result from that. A hip injury is not something that people just can walk out at easily and continue with their lives. So you have to understand that there's a reason why there is an investment in this primary care looking for this particular disease. It decreases the quality of life if you end up with disabilities related to movement or mobility. It decreases your function and it decreases independency. And that's the worst that can happen to our elderly population. We want our patients, our 65 years and older, to continue to be independent and thriving in their communities. It increases morbidity and mortality. It's associated with 20% excess mortality a year after a hip fracture, for example. And the rate of death in men is nearly double than in women when they have any of these fractures related to osteoporosis, especially this hip fracture. And the normal remodeling process is again, this is oversimplification because we want to put it in a way that people can easily understand it. We're talking about bone resorption and bone formation, that it's happening through all our life. And our body has the capability of doing that effectively until we hit those ages that hormonal help is not there and other environmental factors start hitting hard on the person's reserve. the remodeling cycle may become unbalanced. And we see that after the menopause in women and after aging in men and women too. And to be a consequence of illness or medication, as I said, secondary osteoporosis, which we still need to treat. And bone resorption increases more than bone formation. And this is when you get those brittle bones, resulting in a net bone loss. When we're talking about intrinsic factor, it could be genetics, just as it is. Our grandfather had it, our mom had it, and there it comes all the way down. And it accounts for 75, 80% of the person's peak bone mass. So if your family, nobody really did have that bulky bone formation, there's no way you might inherit that bulky bone formation. It might be more prone to developing osteoporosis later in your life if the conditions favor it. And then another thing is change in sex hormones. And we know that it's postmenopausal is very underlying of suffering these diseases. It's a sharp decline in that estrogen protection to the bone that women have as they age. And then men, gradual decline of estrogen and testosterone bioavailable with aging. And there you go. There's that predisposition. If it's also genetically applicable. And then other gender and transgender now with exogenous excess hormone supplementation. There's studies undergoing if indigenous production of those sex hormones are more protective or not, because we're now seeing it again in gender and transgender receiving hormonal replacement. And then insufficient skeleton loading. And what we mean by that is those bones that bear weight is important to keep active. For that one of the institutions of the one of the interventions that we institute for geriatric populations is lifting weight because bone or weight bearing bones require that stress from gravity and dynamics, that muscle contraction working. It's part of the remodeling process and it happens normally until we hit those certain ages. And then weight bearing exercises may reduce bone loss in postmenopausal women again. And this is a strain of evidence and it's type B. So every time you see the strain of evidence A, that means there's robust study to support that 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 conclusion when we're dealing with all that research that we have there, all that robust data. Okay, and calcium and vitamin deficiency, what does that mean? As we age, our skin age too, and then there's less sunlight exposure, probably because of the activities, and then there's less efficiency of that conversion of vitamin D in our body, and then we see a drop in and deficiency, of course, of vitamin D. Older individuals, if we're talking about Black individuals, are higher risk of vitamin D deficiency because of that conversion. And then age also decreases intestinal calcium absorption. And again, there we have deficiency of both calcium, vitamin D, which we know is so important, but especially when we're treating individuals with osteoporosis. There's also a secondary hyperparathyroidism, which is a hormone that we have. Normally it's in our neck, right on top of that thyroid hormone, and is dedicated to balance out calcium throughout your body. But if it loses the positive feedback or a healthy feedback, and then you get more reabsorption of bone to increase calcium level in your body. And then supplementation of both calcium increases bone mass, and that is again a strain of evidence B and reduces fractures in some populations. We also have seen that. And then when we're talking about those factors that you can modify, those we can definitely do. And we're talking about smoking is associated with osteoporosis. Chronic alcohol use, we're talking about taking more than 3 drinks a day at any point. Malnutrition, lack of weight bearing exercises, sedentary life, or people just bedbound. You need that weight on your bones for that promotion, the growth of that bone. And then there's certain medications, and there's a list. Maybe you can recognize a couple of them, especially diabetics, that we have those inhibitors for diabetes. And then this is a widely used medication, also PPI, which is the medication that we use for acidity. So that's why it's so important if any individual is chronically on use a medication for acid reflux, to evaluate with your doctors and maybe check on your bones density and your bones level because it might be affected by it. And then there is those that for treating cancer, breast cancer, and there's others for prostate cancer that prone the individual to suffer for osteoporosis, and there are preventative measures when we start giving those medications to individuals. Also for antidepressant, SSRI is very commonly used so off in our geriatric population, and we know that it predisposes individuals to bone loss. And then now we have corticosteroid. These are secondary causes of it. If you're on prednisone because you have COPD, that chronic obstructive pulmonary disease, you might be receiving chronically, or if you have any immune compromised condition, autoimmune conditions that are treated, frequently treated and chronically treated with prednisone. Hyperparathyroidism, as I said, primary, a male hypogonadism because it's again associated with sex hormones. Vitamin D insufficiency, also just by replacing vitamin D, we can get that calcium level up and the bones can start forming and developing that bulk that it needs. Malabsorption, multiple myeloma, and other conditions, including their, again, alcoholism. Osteoporosis is preventable, and that's the important thing. And it's associated with a high GBD expenditure from the United States to treat individuals when they end up institutionalized because mobility is now a huge problem and they're not independently living in the community. The diagnosis of osteoporosis should be considered any patient, an older patient, we're talking about 65 and older, having a fracture or more than 60 for that matter. And then BMD or bone mass density measurement is used to establish this diagnosis in those high clinical cases, but without a prior fragility fracture. If you have that fracture and you have some bone loss, automatically you receive that diagnosis of osteoporosis. And then we have that FRAX tool that I was mentioning. It's a questionnaire. It goes on your lifestyle, different things, and is a great predictor. It gives you the heads up if an individual might suffer from osteoporosis later on following the 10 years after they did that questionnaire. So it's the most widely adopted. It uses a variety of clinical information to model the 10-year fracture risk of an individual in the community. We're talking about community dwelling, older adults, and it can be calculated or without BMD. But you can also, if you already have some sort of reading from your bone density mass, you can include that in the FRAX calculation. There is limitations to this tool. Unfortunately, it's not perfect and it doesn't account for fall risk. It's not valid for individuals less than 40 or more than 90. And we know there are 90, normally their bones are very brittle. And then it also doesn't include or currently on osteoporosis treatment, it relies on bone mass density at hip, which can underestimate other bones that might be brittle and it might predispose the patient to a fall. And it's validated for ethnicity, white, black, Hispanic, and Asian, which pretty much covers a big population of the United States of more, most of it. Postmenopausal women and men over 50 years who meet the criteria for osteoporosis with DEXAs or have a hip vertebral prior are indicated to get treatment. And the NATIA, National Osteoporosis Foundation, recommends consideration of treatment for 10 years probability of hip fracture in anybody who has more than 3% of that risk within those ages, or major osteoporotic fracture of more than 20% as calculated by FRAX. So these are the individuals. However, what can we do? What we can modifications to our lifestyle style we can do to try to decrease the risk of fractures by osteoporosis. And remember, staying physically active by participating in weight bearing exercises such as walking or soft lifting of weights, it's highly recommended. It's drink alcohol in moderation, which means less than 3 a day. If you're chronically drinking that, you might be a higher risk of developing. Quitting smoking or not starting it if you don't smoke. If prescribed, take your medication that medication can help prevent fractures in people with osteoporosis even before a full reversal of the disease. And a nutritional diet rich in calcium and vitamin D helps maintain good bone health. And remember that any vitamins, vitamin D that you absorb from the food and calcium from the food, it's more effective than any pill because we know the absorption of pill is very limited. So exercise, calcium and vitamin D, as I mentioned, pharmacologic options. We have medications out there. And once the disease is declared or the frask is very high, then is the indicator to start treating individuals to reverse that bone loss. Biphosphonate is the safest. I mean, studies are been incredibly robust in biphosphonate. So is the first treatment. It's the most cost effective way if we're talking about giving medications to individuals. And then we have others is like the rank ligand inhibitor, and we have selective estrogen receptor modulators, and we have calcitonin. But there is it's a few cases it's indicated to use those. And then anabolics, which we highly recommend already there, going to see your endocrinologist specialists in osteoporosis. They're very good at sitting down and evaluating alternatives for patients and monitoring. And then we recommend the calcium intake, of course. And for postmenopausal women or more, any woman more than 50 years old, or man anywhere more than 70 years old, we recommend 1200 milligrams per day of that element calcium. And men 51 to 70 years old, 1000 milligrams per day of element calcium. And the average diet should be enriched. We recommend also having a nutritionist when we're talking about multidisciplinary approaches to reverse osteoporosis. And that intake of postmenopausal women should be around 500 to 700 milligrams. If we're giving supplementations, remember to divide the calcium in 600 milligram pills at a time because higher than that, it's limited at absorption. It's not going to do much, and you get the side effects of increased calcium, which can include it's constipation and other sort of things that you should sit there and just evaluate with your doctor. And we recommend a maximum of 2500 milligrams a day. And in terms of vitamin D, we use units to vitamin D. And for men and women, 55 to 70, 600 units a day. Men and women more than 70 years old, it goes a little bit higher. So more than 800 units per day with a maximum of 4,000 units per day is recommended. This is one of these vitamins that if you give a lot and it's excessive in your body, you can get intoxication of those. It's very rarely seen, but it's seen. So we also recommend that if we're treating and we're giving medications for osteoporosis, we check on those levels every time the patients or when indicated. And then there's an ongoing controversy around routine vitamin D and the targets level that we should gain there. So the AGS in 2014 came to a consensus to treat individuals with 25 hydroxy vitamin D with a level of 30 or more. Vitamin D and calcium supplementation alone have not been shown to reduce the risk of fractures for community dwelling older adults. So there is also that exercise and modifications of lifestyle to help out bulk up and build up that bone again. The greatest benefit of supplementation is likely from for how a homebound individual and institutionalized individual with having sufficient intake and are the highest group of fractures secondary to osteoporosis. So these are a couple of medications biphosphonate. If you compare them, alendronate is very widely used. Remember that the medication that we know the most is the one that we relay on, and then we check always side effects. Resinitrate, it's another of those alternatives out there. Ibandronate and zoledronic acid, especially those that are in conditions that have like severe regurgitation. We know that biphosphonates are associated with esophagitis, which could be an inflammation of those individuals that are continually having the regurgitation. So, other alternative based on clinical conditions should be taken into account. And then moving quickly. And I know that it's a lot to take in. And again, this is very oversimplistically placed because we just want to give you that information and create awareness of situations that are out there that could be affecting you. If you're a senior, if you're more than 65 years old, if you're a woman postmenopausal, if you're a man and already a senior. So these are conditions to look after. And then now moving to what we know, a power of attorney, which is another big topic. Our seniors have situations, right, where, we're just sick or individual, anything could happen, even in very, very healthy senior thriving in their community. There's those instances when we need to prepare ourselves and give those tools to our loved ones and people that we can trust. So if we're not around or capable of making those decisions, we know that our wishes are respected and we know that the people that love us represent us when making those legal decisions. And there's a couple of things called a legal power of attorney. And when we're talking about it's this is a power granted to a person, the power to act on behalf of another person when the situation requires. And there's that general power of attorney that it's frequently granted for a limited time or purpose. If the individual is sick and the individual is in whatever condition, it affects your capabilities of making decisions. At some point, you might need to be represented by those that love you. For example, in a real estate transaction, the property seller may give his or her power of attorney to sign closing documents on his or her behalf. In this case, the property seller is the principal or attorney in fact. And then once they're closing in, the power of attorney is no longer effective. The agent can no longer sign documents on behalf of the principal. And just to set an example, my daughter is no longer in the country and she had affairs that I needed to take care of. So this is where that power of attorney with limited time, it's in effect, so I can represent her managing things that need to be addressed immediately. But there's another type of power of attorney that we wanted to share with you tonight, and we're talking about durable power of attorney. And then, however, some powers, and this is the way it's described, are not limited because of the situation or the time of subject matter. They're given permanently to individuals that represent us. In this case, a durable power of attorney is still in effect even after the principal is incapacitated. The durable power of attorney ends only after the principal dies. And therefore, durable power of attorney documents are very useful in estate planning tools. And then care durable power of attorney helps your family members continue your health care interruptedly if you become disabled. Additionally, your family members may use a financial durable power of attorney to ensure that your bills continue to be paid. And we have a lot of patients that opt for those, like, doctor, I want my children to represent me. I always consult them. They're always in there and I trust their decision making. And for some reason, they want to give that power of attorney to their loved ones. For whatever situation, it doesn't matter as long as you are aware of the power that you're providing others and that when you're no longer there to make those decisions because whatever situation you're incapable of making those, you're sick, you're in a ventilator, anything bad happen, or and so you know that the people that you're entrusted represents your best interest. We also have that all 50 states right now permit a durable power of attorney. Each state has is a form that is created by the state legislature that individuals may use. Illinois, for example, the law provides a form of durable power of attorney, which I have the links and I can share with the communities that you can look there for free. You can sit down, check on those, check exactly what powers are you providing others when they're representing you, and durable power of attorney for property and finances too. Also, healthcare, the forms are found in Illinois state statutes and may be modified as necessary. For instance, the Illinois durable power of attorney for property allows your agent to enter into loan transactions on your behalf. However, you may aim, you may amend this power, or you can even delete it. So it's not all that says there, it's what you choose that says there it's going to be what this agent is going to be representing you for. So those are important considerations when we're talking about that. If you become disabled or incapacitated and you do not have a durable power of attorney, your family may be unable to make decisions on your behalf. They must institute guardianship procedures. That's another legal form to make your health care and financial decisions. Guardianship proceedings are generally straightforward, but they take time and additional expense when your family might be reeling from your dramatic change in health. So, those are considerations and options, alternatives that you have out there. And we want to make sure you're aware of them in cases needed, because the worst thing that could happen is that you're not around and the court has to make the decision of who represents you. And sometimes we have seen not so favorable outcomes of the state, for example, representing when there were children around, but they weren't able to be accounted for, or situations that happen. So at this time, you appointing this individual, either is your a neighbor, or it's a family member, a trusted, your children, your wife, your spouse. It's important to make those and put those in writing for when the time comes, the right individual makes your decisions for you. So I'm open for questions right now.
Thank you so much, Dr. Luna. We're just gonna take a look at the Q&A to see if there's any questions, or if anyone has any questions, please make sure to use the Q&A option. I think as of right now, I do not see any questions available right now. Priyanka, I'm not sure if you see anything different. Oh, actually, we just got one. Um, what do you recommend for elders recovering from a hip fracture?
Yeah, and this is very important that once a hip fracture is there, there's a couple of things we always do. We go into, first of all, into disciplinary approach. There's important to know the state after you end up with a fracture. Where are you going to go? If you're going to go home, if you have social support to be at home, you have family members that can help you out, a neighbor, somebody responsible, depending on your needs. For the most part, individuals with a hip fracture that, for example, needed intervention, a surgical intervention to put it in place, or that for some reason, I'm going to explain both extremes. So if you have like already been after a surgery and everything looks good, the next thing is we always evaluate if it's easier for you to start your physical rehabilitation at a skilled nurse facility, or if you can do it from home. There are particular, preferences for individuals like, no, doctor, I cannot, I just will not go to any institution for that matter. Or yes, I will. It's easier because I know that being there, I'm going to get my physical rehabilitation interruptedly. So they rather go there. They get their physical activities done daily. Depends a lot on your reserve as an individual. And or if you can, if you're very, very strong and your reserves are very high, you can start getting that physical rehabilitation at the hospital. It's called subacute rehabilitation, but it's only individuals can engage physical activity for more than 3 hours in a row. So we're talking about people with a lot of endurance and resistance and capacity to endure and do their physical rehabilitation. Another thing that we always do, and most of this happens, is individuals go into treatment for osteoporosis after a hip trauma or fracture related to osteoporosis. We're talking about different causes is a different approach. But if the individual has proven to have osteoporosis, we give medications to those, make sure compliance is there, vitamin D and calcium, normally supplementation to reach those goals are in there. And then modification, if it's a smoker, it would be very beneficial for the individual to stop smoking. Or if they're a drinker, it will be beneficial for this individual to stop drinking at that point. So it's a multidisciplinary approach. You get a physical therapist, you get a nutritionist if you have osteoporosis, you get normally a recommendation or referral from your internal medical doctor, family practitioner, or your MP or whoever is your primary provider to go and start seeing your endocrinologist And we start like that full implementation of medications, and in 2 years we have seen incredible outcomes in individuals reversing that detrimental bone state that they were when they had a fracture or so forth, and coming back to life, if I might say it like that, with very, very healthy bones. So we see everything. And I hope we don't see you getting any fracture anytime soon, because preventative interventions are there to avoid catastrophic effects, including institutionalization.
Thank you so much for that answer, Dr. Luna. We do actually have another question. This person asks, do you have any information on how a person can become a caretaker of their seniors at home?
Yes, and let me just open very quickly. Let me just open again what I was sharing initially, and then let me just go back. Where it was right here. I'll just show you right here. Let me open this, and I hope you guys can see it from where you are. This is a form of power of attorney, and it gives you all the indications here for the state of Illinois. The ones the one that I'm sharing with you is the state of Illinois, and every state have a particular way, a particular form that they have to fill out. But if you already filled out, if the patient did that, or you as and you're appointed an agent and you're moving from state, there's legal things that you can do to make that power of attorney effective in the new state that you're taking the person that or either doesn't want to make those decisions, is delegating those decisions to their agent, or they're incapacitated to make those decisions. So a couple of things: individuals that represent you have to be 18 years and older, for example. And the limitations to this agent that you choose is that they're not much, but the information that they go one by one, and it's important that the patient or the person that is appointing their agent understand, is the degree of power that you're giving. If it's going to be some power of attorney, or is it going to be a durable power of attorney? Because that one is for life, unless if a capable individual of making decisions wants to reverse those, there is legal way to reverse those documents, and we have seen those as well. So this link I'm going to share with you so you can look at the form. Those normally we look at the form is it's a free form that you can fill out, and then we highly recommend, and we have resources out there that you go and check it out and legalize this with your attorney. And depend on the extent, it's only if you're only you only want legalization or an affidavit of your signature, the power of attorney is full in effect once you put your signature on it. So there's a lot of things that you can share there. Of course, because of time constraints, I'm not going into depth, but I just want to make it aware, make you aware that you have it, and so that people understand their rights when you're looking for that individual is going to represent you.
Thank you, Dr. Luna. We actually have two more questions. I'm going to start with the first one. What is the price of a power of attorney?
The power of attorney, you can even get it for with put it in full or legalize it, or getting legal consultation completely free. So for example, in the state we have resources out there, especially those individuals in high CVI, which are, we're talking about vulnerability index, where we know that financial situation is a strain. So we have all those consultations for free. Even ARPA, I don't know if you have heard of that. It's an organization dedicated for affairs in our elder population. They also have resources available for them. But all that you can get through the city, for example, the mayor's office, you can get all that information just calling 311 and, hey, I want legal consultation. I can't really pay for it, or and I want to sit down and discuss those. So there's a lot of ways to do it. If you're computer savvy or your children are, they can do it online. They can fill out those forms and get that legal consultation online. But the form is completely free, available online if you want to get it. Even it could be mailed to you by any of the nonprofit organizations who work directly supporting our elderly population.
And with the next question, Dr. Luna, this person asks, does the endocrinologist specialize in osteoporosis?
Yes, endocrinology is a specialty that dedicates, and we have amazing endocrinologists here in Chicago. There's even ongoing research, clinical trials in medications, performances, interventions. There's a lot of that also in the University, for example, of Illinois, which is a state university. We have it also happening as particular hospitals. Northwestern have their own group, but they're incredible. And if we follow the instructions as the recommendations are being given to us, it's the outcomes are incredible. So this is why we're so on top of osteoporosis, because it's preventable. And even if you develop it, you can reverse it. And most of the time, it can take 2 years if your body responds very well to the medication chosen by you and your doctor, or it can take a little bit more.
Thank you so much. Does anyone have any more questions? Please continue to use the chat or use the Q&A box.
Thank you, Dr. Luna. I'm just going to wait for questions to come in, but I just wanted to follow up with some links in the chat box. So the link that Dr. Luna provided is in the box for the medical power of attorney. And if you're interested in becoming a certified caregiver in the state of Illinois, there's also a link for that. And if you have a family member that you want to become a paid caregiver for, there's also a link. So there's 3 links in the box. Feel free to click on it and take a look later at your own discretion if you're more interested in learning about any of those topics.
Thank you, doctor, for mentioning that. We have, as a geriatrician, we see it all the time that a lot of our elderly will, they're not so independent, and ADLs, IADLs. And when we say ADLs is basic activities of daily living, or a little bit more instrumental, like managing your own finances, managing your own appointments, getting your medication, taking it on time, for all the array of conditions that can impede that from happening in our patients. And there's a lot of need, necessity in children, grown children that can take care of their parents, are not able to do that sometimes because they need to get work for their families, and financially they're in no position to stay home and take care of their elders. So these links that Dr. Priyanka is sharing with you gives you alternatives, and where to look into the state. We have the Department on Aging, which for those individuals that need those resources, and we're talking about refugees, we're talking about undocumented immigrants, and we're talking about uninsured individuals, that we can sit down and help those find a way of getting compensation, financial compensation, so they can stay and take care of their loved ones that need them the most at this time.
We do actually have one more question that came in. Um, does the person who has the power of attorney, can they reverse or modify a will?
Yes, once the power of attorney is granted, well, this individual inherits the full power listed in that power of attorney. The individual that can make modifications of the power of attorney is the patient that it's choosing that agent, or the individual that it's choosing who they're giving that power to, and what powers are they're delegating to this appointed individual. So once you have it, there's no need for you to take away a couple of things. If you're the agent representing your loved one, for example, I'm representing my mother, who gave me the power of attorney for her medical decisions. There's no need for me to be modifying and taking powers away from myself that my mother gave me. But my mother can make those adjustments and decide what power she is going to be granting me through this power of attorney.
That sounds great. We actually did have another question coming in as well. When the person is in a nursing facility, what rights, if any, does the family have?
Yes, well, whoever is when there is no power of of attorney appointed, we use what it's called next of kin. It's that individual that has been involved. It could be the son, daughter, it could be the spouse, normally the spouse, by definition, if they're in a legal, if they legalize their marriage, well, there are certain things that automatically they represent. But anybody that is the next of kin, and those decisions are pretty much dictated by state, that individual represents the patient, and in consultation with the patient, if they're not decision makers. This is an important thing to just state here for a public, that one thing is, if you can't make decisions medically at some point, decision maker, which we call it medically related. And another thing is competency provided by you, by a court. If you're incompetent to make decisions dictated by a court, those are two different ways of granting authorization for anything. So decision making is that a patient maybe momentarily or temporary lost their ability to make those decisions. They're delirious, or they're in heavy medications for whatever reason, or after a stroke, or but something that can be changed, or time can change this condition, and they can come back and be those decision makers and decide over the medical care. Or if something else is it's bigger, and then you decide, or the family goes to court to get the guardianship, because this patient is declared incompetent by court. Those are two ways to do it, and one of them requires like jurisdictional approval by the state in a different route of doing that. So family do represent, especially that who designates themselves at the next of kin, is going to be attentive or taking care of their loved one, or making those decisions. And for the most part, if the patient can make still decisional, and he appoints this individual, like, I'm not going to do any medical care unless my daughter agrees with it, or unless you inform my daughter. This is the way that we involve the family, and that's the right that the family have. But no family can trump a decisional individual unless a power of attorney is granted, or they're the legal guardian of that individual.
Thank you so much, Dr. Luna, for taking the time to answer these questions. I do want to let everyone know that if for any reason we weren't able to answer any of your questions, or if you feel like you still want to ask any extra questions, please feel free to forward them to Priyanka Reddy, the health equity organizer from the Southwest Organizing Project. Their contact information will be listed towards the end of the presentation. And with that, Priyanka, if you could please move to the next slide. I'd like to pass it over to Eddie. Thank you so much again, Dr. Luna.
Yeah, I'll get the slide up. Give me 1 second.
Okay. Hello, everybody. My name is Eddie Dominguez. I'm a public health ambassador, team leader with the Southwest Organizing Project. Thank you so much for participating tonight in this webinar. And we want to invite you to the following weeks. I have a few announcements as well. So there's a change. We're doing something different next week, and the week number 4, the subjects both weeks is going to be mental health, but this time, instead of being a 1-hour session, this is going to be a 2-hour session. 2-hour session for the Spanish on January 24th for mental health, and a 2-hour session for English for mental health. For the Spanish one, we will have our presenter will be Guadalupe Rosas Rico, a qualified mental health professional, as well as a licensed social worker. And on January 21st, for the English session, it's going to be Marcos Montes, community behavioral health liaison. So again, this will be a 2-hour session. We're starting at 6 and ending at 8 each week. If you have any extra questions, please forward them to Priyanka Reddy. She's our health equity organizer from the Southwest Organizing Project. And you can see that in this slide, and you could see the email in the bottom. And I also want to remind you that the Southwest Organizing Project can connect our community members to additional wraparound resources, such as the ones listed on this slide, help to apply for health benefits, Medicaid, health benefits for immigrants, also food benefits. We have other programs that we can refer people to, like the Career Path Employment We also assist people applying for citizenship, applying for the DACA, renewing DACA, or legal aid in immigration, and the other ones that you can see right there listed. Priyanka just shared the link to this form. You can also, you see right here on the slide, QR code. The link that Priyanka just posted is the same, it points to the same form. It's an intake form where you can put your contact information, your name, and something that an assistance that you or somebody that you know is interested in. And then, you know, in maybe one day or so, a PHA, a public health ambassador, will get in touch with you to follow up and see how best we can connect you to the resources that you need. So again, you can scan the code right here, or you can just click on the links that are on the chat box. Thank you so much for participating tonight. And again, we invite you to come every Tuesday until we're done with all these series. As you can see, these are very, very valuable sessions where you can learn about well, several health subjects. Invite your friends, connect other people to these webinars. Thank you so much for doing so.
Thank you so much, Eddie. We definitely really appreciate it. Special thank you to Priyanka just for organizing this whole event, and to Dr. Luna for taking the time to be here with us. And honestly, just a big thank you to everyone who was able to attend today and participate. We hope that you have a great rest of your night. If you're interested in sticking around for the Spanish session, please go ahead and stick around. That should be starting at 7 as well. So thank you, everyone, and hope to see y'all again.